Dear colleagues, this presentation is prepared for clinical key for electrical stimulation in physiotherapy and rehabilitation project. The project partners are Pamukkale University, University of Craiova, Hatay Mustafa Kemal University, Başkent University, Süleyman Demirel University, Şilay State University of Applied Science, Burdur Mehmet Akif Ersoy University, and National Physiotherapy Associations. I am Özlem Yürük from Başkent University. The subject is electrical stimulation for patients with chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, or COPD, is the general name for a group of progressive, partially reversible disease characterized by airflow limitation. Dyspnea, wheezing, cough, chest tightness, and frequent respiratory infections are the main symptoms of the disease. COPD is a systemic disease with multiple extrapulmonary manifestations, including inhibition of skeletal muscle function, leading to reduced muscle strength and endurance, fatigue, weight loss, and anxiety in individuals. In COPD, limb muscle weakness, atrophy, structural and metabolic changes are observed. And these problems in peripheral muscles have a negative effect on exercise tolerance. Pathophysiological mechanisms underlying peripheral muscle dysfunction in COPD are protein synthesis, degradation imbalance, nutritional abnormalities, muscle disuse, systemic corticosteroids, hypoxia and hypercapnia, changes in muscle remodeling, inflammation, oxidative stress, and mitochondrial abnormalities. Changes in the structure of peripheral muscles in individuals with COPD are conventional from type 1 fibers to type 2 fibers, reduction in cross-sectional area of type 2 fibers, and decrease in capillary and mitochondrial density, decrease in the rate of oxidative metabolism. As a result, muscle strength and endurance are decreasing. The loss of muscle strength and endurance are especially in lower extremity muscles causes decreased walking capacity and physical activity. These are associated with exercise intolerance, morbidity, mortality, increased healthcare use, dyspnea, and poor quality of life. The main goals of physiotherapy and rehabilitation are to reduce and control symptoms, improve physical capacity, ensure independent function, reduce the frequency of hospitalizations, reverse the effect of disease on the system, increase physical and emotional participation in the life, increase the quality of life, and reduce the health-related care resources. Before the clinical decision-making for physiotherapy program and electrical stimulation, detailed patient assessment is necessary. The physiotherapist should interview the patients. First, a review of the medical record can help to identify the patient's medical history and precautions. It is needed to explain the purpose of the electrical stimulation. The physiotherapist should observe for signs of anxiety, dyspnea, confusion, fatigue, abnormal posture, limitations of activities, daily living, and reduced endurance. Also, it is necessary to learn the patient's previous medical condition for contraindications of electrical stimulation. The aim of the physiotherapy and rehabilitation assessment is to establish the patient's functional ability and limitations. The content of the physiotherapist's assessment may vary to individual and setting to setting. In individuals with COPD, dyspnea, posture, range of motion, anthropometric characteristics, strength, endurance, sensation, fatigue, and quality of life should be assessed. Exercise training, patient education, pulmonary physiotherapy, and electrical stimulation are used in physiotherapy and rehabilitation programs of individuals with COPD. Among the electrical stimulation approaches, neuromuscular electrical stimulation, functional electrical stimulation, magnetic field stimulation, and transcutaneous electrical nerve stimulation are the most common interventions for COPD. An exercise-based pulmonary rehabilitation program is the main approach for COPD. However, some individuals with COPD cannot reach the required level of exercise intensity due to fatigue symptoms and cannot continue the exercise for a sufficient time, even in the first stage of resistance exercise training, since their functional exercise capacity is extremely limited. Also, severe dyspneic individuals with COPD cannot complete the program. Neuromuscular electrical stimulation is indicated as an alternative to increasing peripheral muscle strength in individuals with COPD who cannot perform the resistive exercise. Electrical stimulation is generally applied to the thigh and calf muscles of the lower extremity. The upper extremity or diaphragm can also be stimulated. Passive training of specific muscle groups with neuromuscular electrical stimulation can be tolerated better than active exercises in individuals with COPD who cannot do active exercise due to severe ventilatory limitations and dyspnea. The metabolic load is lower during electrical stimulation than resistance exercises in individuals with COPD. Therefore, it doesn't increase the load on the ventilatory and cardiac systems. Because of the constant metabolic load in combination with stable symptom scores over time, it seems reasonable to hypothesize that the improvements in muscle function are at least partially due to intramuscular changes. Previously, it has been shown that type 1 and type 2A fibers increasing following low frequency or high frequency electrical stimulation. Electrical stimulation can be used stable and critically ill patients with COPD. Electrical stimulation can regulate peripheral microcirculation, prevent atrophy by reducing muscle protein breakdown, prevent weakness associated with intensive care, and shorten the weaning time. As a result, electrical stimulation is a useful training method to improve lower extremity function, especially in individuals with COPD with activity limitation and intolerance to whole body training. Neuromuscular electrical stimulation can be applied in bedridden patients admitted to the intensive care unit for acute COPD exacerbations. The NIMES can improve muscle function in these environments and facilitate the transition from bed to chair. Latimer et al. Compared electrical stimulation and resistive exercises have a broader impact on muscle RNA abundance and therefore appear to be a superior intervention for maximizing transcriptional responses in the quadriceps femoris muscle of the patients with COPD. However, if voluntary resistive exercises are not feasible in clinical setting, electrical stimulation can modify the expression of genes and improve muscle mass and strength. The effects of electrical stimulation in patients with COPD are to prevent atrophy, increase peripheral muscle strength, regulate microcirculation, decreased perception of dyspnea, strengthen without increasing the metabolic load in the voluntary and cardiac systems. And here is the parameters settings for muscle strengthening in COPD. NIMS neuromuscular electrical stimulation parameters can be determined according to the specific needs and reactions of each patient, rather than establishing a uniform protocol for all individuals with COPD. However, a general outline of the electrical stimulation protocol is shared in here. The treatment is directed to the quadriceps femoris, gastrocnemius, deltoid, biceps brachii, abdominal, and diaphragm muscles. In neuromuscular electrical stimulation, it is recommended to prefer biphasic, symmetrical, or asymmetrical currents in the 35 to 50 Hz frequency range with a stimulation duration between 100 and 400 microseconds. The parameters are well tolerated by the participants. Oxygen uptake, ventilation, and symptoms doesn't differ between the high frequency or low frequency electrical stimulation. These specific values provide maximum activation of slow twitch, fatigue resistance muscle fibers. In neuromuscular electrical stimulation application, high repetitive muscle contraction is considered appropriate due to the relaxation of the muscles and considering the rule that duration of contraction is similar to endurance training. After the contractions, intervals adjusted according to the patient's fatigue level are given. The data obtained emphasize the determination the most appropriate contraction and relaxation rates for the patient without causing excessive fatigue in the muscles. It has been stated that the gains in functional exercise capacity achieved with electrical stimulation are largely depend on the patient's ability to tolerate and maintain increasingly higher current intensity. It is recommended to have a variable amount of visible but clear contraction and to be increased up to patient's maximum tolerance. The total treatment duration is 4 or 8 weeks for muscle strengthening. It has been reported that the frequency of treatment can vary between 2 or 5 per week, and the duration of a treatment session can vary between 15 to 60 minutes. Electrode placement is decided according to the muscles to be stimulated. Electrodes are placed parallel to the fibers of the limb muscle. Stimulation can be performed unilaterally or bilaterally. The therapists use 2 or 4 electrodes. For diaphragmatic electrical stimulation, a total of 4 channels and 8 electrodes are used. 2 channels are placed upside down on the both sides of scaphoid at the level of intercostal space of the 7th and 8th ribs with 2 electrodes. For abdominal stimulation, 4 electrodes placed approximately 2 centimeters from the umbilical region bilaterally and symmetrically around the midline. And here is the electrical stimulation parameters for endurance training. These parameters are the same with strengthening parameters, but the amplitude should be 25 to 50% of maximum voluntary isometric contraction, and the duration is 15 to or 30 minutes. Studies using neuromuscular electrical stimulation to increase peripheral muscle strength in patients with COPD have been increasingly taking place in the literature since the beginning of the 2000s. In studies with neuromuscular electrical stimulation has compared alone or combined conventional pulmonary rehabilitation and neuromuscular electrical stimulation versus control or sham or pulmonary rehabilitation on disabilities and activity limitation in patients with COPD. Roig and Reid's systematic review stated that moderate improvement in muscle function and exercise performance gained with the electrical stimulation applied to the lower extremities of patients with COPD compared to control, sham therapy, or other treatment groups. In the related review, while electrical stimulation is an additional approach to be used in the rehabilitation of patients with capacity to exercise, it was reported that it can be a primary treatment approach in critically ill patients where long-term immobilization is required. However, it is also noted that neuromuscular electrical stimulation has no advantages over voluntary exercise training. Individuals with COPD have low lower extremity muscle cross-sectional area, lean body mass, fat mass, and fat percentage. Vivotsev et al. Compared the effects of 4 weeks of rehabilitation and electrical stimulation added to the rehabilitation program of patients with severe COPD with low body mass index. They found that body mass index increased more in neuromuscular electrical stimulation group. And Zanotti et al. Found improvement in muscle strength and a decrease in number of days needed to transfer from bed to chair. Dal Corso et al. Concluded that hypertrophy in type 2 muscle fibers with electrical stimulation. However, this was not translated to increase skeletal muscle strength and exercise capacity. Leite et al. Found that NIMES application to the diaphragm provides a significant increase in respiratory muscle strength. And Hill et al. Said that electrical stimulation with traditional exercise training doesn't provide additional gain in quadriceps femoris muscle strength, but improves 6 minutes walking tests results. Akech found improvement in static and dynamic balance and exercise tolerance, and also reduced fall risk in COPD patients with electrical stimulation. A home-based pulmonary rehabilitation program, including controlled breathing training and electrical stimulation superimposed onto voluntary muscle contraction, can improve cardiorespiratory performance and functionality in stable patients with COPD. Cookart et al. Found that Home-based pulmonary rehabilitation, including self-monitored electrical stimulation, seems feasible and effective for severely disabled patients with COPD. In the study, the patients were administered electrical stimulation to bilateral quadriceps femoris muscles with surface electrode with a portable stimulator. The patients increased the intensity up to the maximum tolerated level. Neuromuscular electrical stimulation was simultaneously applied to both sides for 30 minutes twice every day. Another study from Bonavi et al. Showed that home-based neuromuscular electrical stimulation as an add-on to pulmonary rehabilitation didn't result in further improvements in subjects with severe to very severe COPD. Moreover, it might have been a burden for some patients. If neuromuscular electrical stimulation is recommended for home-based use, the patients and caregivers should be educated about the application. The physiotherapist should provide information about the risks that may occur during the use and monitors the patients regularly. And functional electrical stimulation. Functional electrical stimulation cycling was developed at the end of the 1980s. Since then, it has been used increasingly in patients with neurological disorders. The principles of functional electrical stimulation cycling is to electrically stimulate one or several muscle groups during an active or passive task by a computer. It has been proposed as an alternative or complement to voluntary exercise for patients with neurological disorders and optimizes training and improve muscle strength and cardiovascular capacity. Phase cycling, functional electrical stimulation cycling, can effectively increase exercise intensity in patients with COPD in short term. Further studies should evaluate longer-term cycling rehabilitation programs. In the intervention, electrodes are positioned at each extremity of both quadriceps femoris muscle. A rectangular pulsed biphasic current is used, and the intensity is modulated to obtain a palpable muscle contraction. The other stimulation parameters can be identical for all patients. These settings are based on the usual electrostimulation protocols. During cycling, a computer controls the stimulator. The software ensures that muscle contractions are induced at the appropriate pedal angles during knee extension. Following a 2-minute warm-up, the load can be increased to reach the training load determined during the initial exercise test. The patients cycle at a frequency of 50 or 60 rotations per minute for 30 minutes. And magnetic field stimulation in COPD. Very few investigations have been conducted to explore the effectiveness of magnetic field stimulation in patients with COPD. It seems that there is an increasing space for magnetic field stimulation as a therapeutic option in patients with COPD, mainly to contract muscle depletion. Most relevant studies have been published in the field of muscular rehabilitation rather than of the respiratory system. Magnetic field stimulation represents a feasible, well-tolerated, and safe therapeutic option for motor-related COPD symptoms. There was no standard treatment protocol. It should be investigated in which groups of patients and which stage can benefit most from magnetic field stimulation treatment, and indicated the more preciously the fields and modalities of applications of this therapy. Bustamante et al. Investigated the effects of quadriceps femoris muscle magnetic field stimulation in several patients with COPD. The control group, in the control group, the patients with COPD followed only clinical monitoring. Treatment method underwent quadriceps femoris stimulation of both lower limbs. The magnetic stimulation was applied 15-minute sessions with intensity and frequency of stimulation adjusted according to the patient's tolerance. In several patients with COPD, magnetic field stimulation was a well-tolerated therapeutic intervention which didn't enhance muscle oxidative stress while increasing the size of slow twitch fibers. And transcutaneous electrical nerve stimulation in patients with COPD. Single session of acupuncture type TINS on acupuncture points, increasing the forced expiratory volume 1 level and reducing dyspnea in patients with COPD. In stable patients with COPD, acupuncture type TINS demonstrated increase in forced expiratory volume 1 and 6-minute walking distance. Acupuncture type 10 provides bronchodilation by increasing the level of beta endorphins. And conclusion. In this video, the purpose of electrical stimulation used for patients with COPD, application methods, and literature studies are discussed. Neuromuscular electrical stimulation, functional electrical stimulation, magnetic field therapy, and TINS contribute to other therapeutic options, therapeutic interventions within the scope of pulmonary rehabilitation with their beneficial effects such as improving peripheral muscle strength and functional capacity without causing the metabolic load. The electrical stimulation interventions can be used in stable patients with COPD and acute exacerbation stage of COPD. Further studies can be conducted on COPD and other cardiopulmonary system disease to determine the effect of electrical stimulation. Thank you for your attention.